This presentation is meant for the medical students that are rotating through cardiology and have finished the first part of the stress test. Additional information about exercise stress testing will be discussed in this presentation. Additional topics that will be covered include medication effects, stress testing in women, testing post-myocardial infarction, stress testing role in preoperative evaluation for non-cardiac surgery, role of stress testing in assessment of therapy for cardiac diseases, role in non-atherosclerotic heart disease that include valvular heart disease, hypertrophic cardiomyopathy, adult congenital heart disease, cardiac rhythm disturbances, peripheral arterial disease, and we will end by additional uses for better patient triage and disability evaluation. Among the medication effects, there are 5 drugs that are generally discussed. Number 1 is the digoxin. With digoxin, there is baseline ST segment abnormality, and with exercise treadmill testing, the baseline ST segment abnormality worsens. So the ST segment response is abnormal when the person is on digoxin, sometimes making it difficult to see if there is ischemia present with treadmill testing. Beta blockers reduce double product. That means they blunt the heart rate response and the blood pressure response to stress. It does not allow the patient's heart rate to rise and keep the blood pressure under control. Calcium channel blockers tend to blunt the blood pressure response, and they may also blunt the heart rate response. Diuretics, as you know, leads to hypokalemia, and those patients that are on diuretics, we tend to worry about hypokalemia in them, and therefore we are worried about it causing arrhythmias when they go on the treadmill testing. Patients that are on estrogen tend to have more ST segment depression, and that is one of the reasons we get false positive stress tests in premenopausal women. Women may present with atypical manifestation, and they tend to have low prevalence of obstructive coronary artery disease. That does mean that you should be doing exercise treadmill testing in women if they do present with symptoms, and if they are able to bring in a good exercise and have no exercise-induced ST segment changes and have a low risk treadmill score, then it is reassuring. Premenopausal women, as I mentioned, tend to have high rate of false positive test. And here you can see 2 examples. Here there is a test which appears to be positive with ST segment depression, and here with a very fast heart rate, you're not seeing any ST segment depression. If the ST segment depression is not present, that reassures the patient, the doctor as well. Exercise stress testing is done in post-MI patient, provided they have not had any intervention prior to discharge. It's a class 1 indication, and it is done before hospital discharge. However, the stress test that is performed is submaximal stress test, and it is usually done 4 to 7 days after the acute event. And if the patient does not have any chest pain, arrhythmias, and is hemodynamically stable. It is also done 14 to 21 days post-discharge. It is also symptom limited if it is not performed before discharge. And we can also do a stress test 3 to 6 weeks after discharge. It is symptom limited if pre-discharge submaximal exercise stress test was not performed. You can also do it symptom limited even if the pre-discharge submaximal exercise stress test has been done in some individuals. Post-PCI thrombolytic therapy, it is usually combined with stress imaging instead of doing a treadmill exercise ECG testing. Parameters, irrespective of the fact whether it's done with imaging or if it is done post-MI, The parameters we still observe are the functional capacity, heart rate, systolic blood pressure, and absence of ventricular arrhythmias. Realistic goals of exercise testing in post-MI patients are three. Number one, functional evaluation to guide the exercise rehabilitation prescription, advice concerning returning to work and other physical activities, and evaluate the influence of present medical therapy. Stress testing role in preoperative evaluation in non-cardiac surgery is very limited. Generally, we don't do it in patients that have a low preoperative cardiac risk or undergoing low-risk surgery. Exercise treadmill testing is not indicated in those cases. Those patients that have an increased risk and have of a perioperative event but have an external functional capacity, that means functional capacity greater than 10 METs, again, there is no indication for undergoing exercise treadmill testing. Those that are at increased risk and have moderate functional capacity, that is between 4 to 10 METs, it becomes a class 2B indication. Those patients that are at increased risk and have a poor or unclear functional capacity, then exercise stress imaging can be concerned if it will alter management. For assessment of therapy for cardiac diseases, we do it for evaluation of the influence of medication that have been given to the patient to make sure it is effective and it has been optimized. Sometimes it is done prior to revascularization to find out the amount of myocardium that is at risk, and sometimes it is done for arrhythmia evaluation, either pre or post ablation therapy. In patients that are undergoing exercise treadmill testing for coronary artery disease, we tend to assess the heart rate and double product at the onset of ischemia, that is when they have anginal chest pain and or ST segment depression. We also look for arrhythmia provocation with exercise treadmill testing, as it is shown over here in some individuals. Non-atherosclerotic heart disease condition where exercise treadmill testing is useful include valvular heart disease, patients with valvular heart disease who want to participate in competitive athletic sports. Exercise treadmill testing is useful. It is usually combined with transthoracic echocardiogram to assess structural and physiological responses. These include patients with mitral stenosis, patients with chronic severe mitral regurgitation, chronic severe aortic regurgitation, and sometimes we do plain exercise treadmill testing for asymptomatic aortic stenosis, which is of moderate severity. We also do exercise treadmill testing with transthoracic echocardiography to follow these patients over a period of time to define the appropriate timing for surgical intervention. However, exercise treadmill testing for symptomatic severe valvular aortic stenosis has no role. It should not be performed in any patient that is symptomatic and has severe valvular aortic stenosis. That means those patients that have a peak aortic velocity of greater than 4 meters per second or have a valve area less than 1 centimeter square or a mean gradient 40 millimeters of mercury with normal LV systolic function. Aortic stenosis, when present and is asymptomatic, exercise treadmill testing can be performed as long as it is moderate and there is a physician watching the treadmill test when it is being performed. It is never ever done in asymptomatic patients with aortic stenosis who have a peak aortic velocity that exceeds 5.5 meters per second. In case of hypertrophic cardiomyopathy, exercise treadmill testing was contraindicated before. Now it is a class 2A indication, mainly to assess response to therapy, and the level of evidence there is classified as C. For risk stratification, that is, for arrhythmias and blood pressure response, and its level of evidence is B. In order to decide for implantable cardiac defibrillator when other sudden cardiac death risk factors are present, is a class 2B without other sudden cardiac death risk factors. It may be used in those that have no significant LV outflow gradient, that is less than 50 millimeters of mercury peak, and it's a class 2A, level of evidence B, mainly to look for increasing gradient and to look for abnormal blood pressure response in younger individuals less than 50 years of age. The purpose is to look for an increasing systolic blood pressure with a later fall of greater than 20 millimeters of mercury or a fall from start of exercise to greater than 20 millimeters of mercury. In other adult congenital heart disease, exercise treadmill testing is done in cases of repaired and unrepaired aortic coarctation, repaired tetralogy of Fallot, surgically and congenitally corrected transposition of great arteries, and coronary artery anomalies. In case of LV outflow obstruction, consideration of athletic participation requires exercise treadmill testing and is a class 2A indication with level of evidence C. For coarctation of aorta, we look for exercise-induced hypertension, peak systolic blood pressure greater than 230 millimeters of mercury, and that defines the candidates for intervention. We look for blood pressure difference greater than 20 millimeters of mercury between upper and lower limbs, regardless of symptoms, but with upper limb hypertension, that means blood pressure greater than 140/90 in adults, pathological blood pressure response during exercise, or significant left ventricular hypertrophy that would require an intervention. It's a class 1C indication. Coronary anomalies, exercise treadmill testing is done in cases of repaired coronary anomalies as well as residual coronary abnormalities associated with certain conditions like Kawasaki, as it is shown over here. For cardiac rhythm disturbances, exercise treadmill testing can be performed in patients with suspected cardiac arrhythmias, those with sinus bradycardia to look for chronotropic response, patients with heart block to see if the heart block would worsen with exercise or get better with exercise, patients with PVCs to see the prevalence of PVC and to see if it increases or disappears with exercise, patients with non-sustained ventricular tachycardia, but it is not done for patients with sustained monomorphic ventricular tachycardia, except in very selected condition. Class 1 indication for cardiac rhythm disturbances include suspected coronary artery disease with ventricular arrhythmias, exercise-induced ventricular arrhythmias, and patients with pre-excitation. Class 2 indications for cardiac rhythm disturbances include response to medical therapy or ablation therapy in known exercise-induced ventricular arrhythmias. For patients with atrial fibrillation, we use it in those patients that have suspected myocardial ischemia and an initiation of type 1C antiarrhythmic therapy is being considered. To assess adequacy of heart rate control for full spectrum of activity persist in patients with persistent or permanent atrial fibrillation. It's a class 1C indication. And for induction of possible exercise-induced atrial fibrillation in those that complain of palpitation when they go out running or jogging. Ventricular pre-excitation is a class 1B indication, and it is used for both symptomatic and asymptomatic patients with pre-excitation. Example of pre-excitation is shown over here. Patient with a catechol aminergic polymorphic ventricular tachycardia. It's almost inducible by maximal exercise test and is frequently not inducible with programmed electrical stimulation. In those cases, exercise treadmill testing can be performed, but those patients have to be observed by physician when it is being done. It appears in heart rates above 120 to 130 beats per minute and begins with polymorphic PVCs, then non-sustained ventricular tachycardia, and eventually it can become bidirectional or polymorphic ventricular tachycardia. Exercise stress testing is diagnostic in such cases and allows response to therapy that generally includes beta blockers. In cases of long QT syndrome, arrhythmias do not usually develop in patients with long QT syndrome during exercise. However, further prolongation of QT in those with long QT type 1 may be seen. Long QT type 2 has normal shortening. Long QT 3 as normalizes fasting QT interval. The treatment may be given by beta blockers, and that can be observed with exercise treadmill testing. For arrhythmogenic right ventricular arrhythmias and cardiomyopathy, there is no role for exercise treadmill testing. In patients with Brugada syndrome, it may play a role in risk stratifying in an asymptomatic person, but it has no role in symptomatic patients. For assessment of therapy, it's a class 2 indication for any kind of arrhythmias, whether it's for treatment with medical therapy, ablative therapy, surgical therapy, for exercise-induced ventricular arrhythmias. Also, sometimes we do exercise treadmill testing to assess the pacemaker function, especially those that have a rate adaptive pacemaker, to fine tune it or maximize the physiological response. Additional uses of exercise stress testing are shown here. Exercise stress testing has found itself a sweet spot in the chest pain units, where patients with chest pains are placed under observation. Patients that are able to exercise and have been ruled out for MI with normal or minor ST abnormality and are able to walk on a treadmill are put onto the treadmill with a Bruce or modified Bruce protocol to find out if their chest pain is provoked or if they have any ST segment changes. Endpoints of this kind of testing is either negative or positive result, and it helps us decide if the patient should be admitted or not be admitted or needs further workup as an outpatient. Exercise treadmill testing can be also used to define the amount of physical activity a person can perform and also for exercise prescription. It is also used for disability assessment, determination of disability for several cardiovascular conditions, for example, patients with heart failure, ischemic heart disease, congenital heart disease, peripheral arterial disease, and valvular heart disease. In most of them, they should be able to perform at least 5 METs on a symptom-limited treadmill testing or stationary cycle test to pass the test. Peripheral arterial disease, patients come in with calf pain and borderline ankle brachial indices. In those cases, exercise treadmill testing can be performed to find the time to claudication onset and peak exercise time to maximum tolerated calf pain. However, in diabetes, at one time, there was a popularity to have those patients undergo exercise treadmill testing. However, there is inadequate evidence to recommend routine screening of asymptomatic diabetic patients with exercise ECG. I thank you for your attention. If you have any questions, feel free to write to me so we can cover that in the next talk.